Speaking to us next is going to be Dr. Schleider, and she's going to be talking about deprescribing patterns after medical cannabis initiation in older adults with polypharmacy. Dr. Schleider?
Thank you. So, hello everyone, good afternoon. First of all, I want to thank the conference organizers and the scientific committee for inviting me to speak today. I'm honored to be here. My name is Dr. Lihi Bar-Lev Schleider. I'm a clinical cannabis researcher focusing mainly on double-blind randomized placebo-controlled trials and real-world studies. Today I will present to you the outcomes of 6 months medical cannabis treatment in older adults with polypharmacy. Before I begin, I would like to disclose that this study was supported by Tikun Olam Israel. At the time of data collection, more than 3 years ago, I was an employee of the company. Currently, I serve as the medical director at Tikun Olam Adelanto. So in this presentation, I will describe the prescribing patterns that the polypharmacy problems in geriatric medicine. I will share with you some of the prescribing patterns we observed in our elderly population in that study, and we will explore how a broader symptomatic approach can help to reduce the medication burden in that medically complex population. So polypharmacy is a major challenge in geriatric medicine in general, not only in elderly population, but every patient that consumed more than 5 different medications per day is in increased risk for hospitalization, for drug interaction, reduced quality of life, and many others risks. Those risks are amplified due to age-related physiological changes like slower drug clearance and increased sensitivity to medications. Deprescribing is often extremely difficult, even when clinicians acknowledge that deprescribing is harmful, that the medication burden is harmful. Often deprescribing is not that easy because symptoms persist and every side effect is treated with different additional medication. So patients are trapped in a prescribing cascade, and even when there's some method to reduce medication, those methods are focusing on reducing one medication at a time. At the same time, many of the symptoms typically experienced by older adults, like chronic pain, sleep disturbances, anxiety, loss of appetite, spasticity, and others, are symptoms that may be improved with medical cannabis treatment. While those symptoms are usually treated with one different medication for each symptom, with medical cannabis treatment, sometimes we can see overlapping symptoms that improved with cannabis treatment. Even though we have some evidence of older adults that using medical cannabis, there is still limited evidence on deprescribing patterns in older adults with polypharmacy. So The aim, again, so the aim of this study was to evaluate changes in medication burden, improvement in symptom intensity, and of course, changes in quality of life, and of course, safety parameters. This study was a prospective study conducted in a specialized cannabis clinic in Israel. The specialized cannabis clinic that patients have to come to the same clinic to purchase their cannabis allowed us a longitudinal tracking of every clinic visit and of medical cannabis patterns, the treatment patterns. So our target population were all patients that came to our clinic and wanted to initiate medical cannabis treatment that were age 65 years or older and consumed more than 5 different medications per day. All participants were evaluated at intake by a trained nurse, so it wasn't only one, trained nurses, so intake included demographic characteristics, medical history, full medication list including drug name, dose, and frequency, and of course symptom intensity, quality of life, and cannabis treatment recommendations. Follow-up included, so follow-up was conducted after 6 months of treatment. During follow-up, we assessed changes in medication consumption and in all the other parameters that we assessed. So let's see if I can show you. No. So treatment success was defined as a decrease in overall medication count. It was both a reduction in the number of medication consumed by the patient or reduction in the dose. Patients with unchanged or increased medication count were classified as treatment failure. Statistical significance was considered as p-value less than 0.05. We performed standard univariate and paired comparison methods to evaluate changes, and all the results I will present today were statistically significant. So during the recruitment period, 3,123 patients received cannabis license at that specialized cannabis clinic and were aged 65 years or older. Of them, 1,765 also were with polypharmacy, consumed more than 5 different medications per day. During the first 6 months of the treatment, 455 patients passed away. It's 25% of the cohort. Another 16% of the cohort stopped cannabis treatment during the first 6 months. The 2 main reasons for treatment discontinuation were lack of efficacy or lack of safety. And another 107 patients, 6% of the cohort, changed their supplier, so we couldn't track the follow-up in our product, using our product. They already used different products, so we were left overall 919 patients remain in an active treatment. Of them, 724 also answered our follow-up questionnaire. So you can see that this was very, very medically complex population. The mean age was 74. The median number of different medications per day was 8. and almost 1/3 of the population consumed more than 10 or more different medications per day. The most common indication for cannabis treatment were pain, cancer-related symptoms, and Parkinson's disease. Here we can see the distribution of a medication intake at baseline. You can see the medication burden in that cohort, that most of the patients consume between 6 to 12 different medications every day. Patients also reported many different symptoms. 91% of the patients reported pain, and almost 81% reported sleep disturbances, and also other symptoms, weakness, digestion problems, and depression. So the most consumed medication class were opioids, and the most common opioid medications included Percocet, Targin, Tramadex, and Butrans. In our clinic, the monitoring is very, very close, and it's not one fit all. Every patient receives a different product according to the symptoms that he suffers from. We can see that most patients received cannabis oil and used 2 different chemovars. So our results, after 6 months of active treatment, 349 patients reduced medication dose or medication count with 95% confidence interval of 46 to 50%. The median number of medications reduced from 8 at baseline to 7 after 6 months, and only among the group of patients that reduced medication count, the median number reduced from 8 to 6. These changes were statistically significant. Here we can see that most patients, 307, reduced the number of medication that they're consuming, and only small portion reduce the dose only. So the most reduced medication class was opioid, with 35.4% of the patients stopped completely using opioids, about here, and another 11.3% reduced the dose. On top of that, we saw a reduction in other medication class. As you can see, I put only the main ones, but in the paper we will put all of them. We asked the patient to evaluate their pain intensity twice, at first before the cannabis treatment at intake, and then again after 6 months, on a VAS pain scale of 0, no pain, to 10, worst pain imaginable. The median pain reported at baseline was 9. That was reduced to 4 after 6 months. You can see it was unbelievable. It really, one of the major findings of this study, you can see that 75% of the patients rated their pain severe, defined as 8, 9, or 10 on that VAS pain scale. Only 9% rated their pain level severe at 6 months. This improvement in pain, we saw the same improvement in other symptoms. So 86.9% of the patients experienced improvement in their pain intensity, but we saw improvement in other symptoms like sleep disturbances, restlessness, nausea, and more. In total, 94.3% of the patients reported improvement in their overall medical condition. So we did the same with quality of life. We asked the patient to evaluate their quality of life in both time points. You can see that it says only 8% of the patient rated their quality of life good or very good. That raised to 51% of the cohort after 6 months of treatment. Among 716 patients that completed the side effect questionnaire, 11% reported dizziness. That was the most common side effect experience, as well as dry mouth, sleepiness, and other. Those side effects are typically similar to what we know from the literature in other elderly population studies. And in general, 32.4% of the entire cohort reported at least one side effect. So in that study, we saw an improvement, first of all, a reduction in medication count, and that reduction was alongside improvement in many different symptoms. We believe that the improvement in symptoms and not only one symptom, many symptoms, is the reason that we see reduction in medication count. That what allows the patient to reduce their dose or medication in general. So this study provides real-world setting into high-risk population. It has several strengths, of course, large prospective geriatric cohort, real-world evidence, high-level polypharmacy population, and other strengths. But it's also important to take those results in a pinch of salt, because there's some important limitations to the study. First of all, it was an observational study without a control group. Therefore, we report association rather than causation. Second of all, not all baseline patients reported answered the follow-up questionnaire, so we might have a responder or survivor bias. We relied on self-report outcomes. In general, it was a specific clinic in Israel, so maybe generalizability is problematic to every elderly polypharmacy population. Follow-up was limited to 6 months, and patient received more than one chemovar, and the chemovar and our product were full spectrum products, so we cannot isolate the effect and contribute to one specific compound rather than the entire regime of that patient. So as population aged and clinicians are treated with patients that suffer from multimorbidity and high medication burden, it is important to explore new approaches of one medication that can target simultaneously multiple overlapping symptoms, and potentially that can reduce symptoms and allow patients to reduce their medication count. In conclusion, in our study, the treatment was safe, efficacious, and patients were adherent to the treatment. Of course, it's not enough, and further double-blind, randomized, placebo-controlled trials are essential to understand if there's a causality in what we saw. These are the main reference for that presentation, and I want to thank you all for listening.
It's time for us to open the floor for question and answer session. It looks like we do have a lot of hands raising, so we'll go ahead and get started right here.
Yeah, great presentations. Love to see the use of real-world evidence, patient-reported, self-reported data, and having it being considered science. A couple questions. So the first one has to do with, the pain-related studies where we looked at quality of life and had the patients rate their quality of life. Were in their answer sheets or in the discussions, did you break down the factors of quality of life, like, loss of sleep, lack of desire to leave the house, lack of ability to work, those types of aspects of quality of life? And is there a further breakdown that we can look at as far as which of those factors were impacted by the use of cannabis? And then the other question is, there's a lot of information on chronic pain, and I've been to pain management conferences where they start talking about acute pain and post-operation treatment with cannabis. So did we find anything in the studies with regards to post-operation using cannabis, and is there anything new with regards to acute pain? Thank you.
So I will. Is it working? Okay, I will answer your first question. So yes, we did break down the quality of life. So because of the time limit, I couldn't show you everything, all the results, but hopefully soon the paper will be published so you can see everything. But I will answer your question. So on average, the patients at intake reported 8.3 different symptoms for each patient. Those symptoms, you saw the main one was pain and then sleep disturbances. So on each one of those symptoms, we followed and we wanted to see the change. So of course we evaluated that. And also in terms of quality of life, we asked the patients about their performance in active of life performance. Many things that they need to deal with on the daily basis, both at intake and after 6 months. And I couldn't show that, but the results were similar to what I presented.
My question is for Dr. Schleider. This study and others that you've done use the 0 time point and the 6-month questionnaire. So in between, do you have information on which patients follow up with their healthcare professional and whether or not that has an impact on success or failure?
Yes, so thank you for that question. It's a very good question. I want to say that yes, we contact all patients after 1 month of treatment. It was something that the company did. First of all, we told all patients that we are available for any question because we wanted to solve any problem, if it's adverse events, if it's other problems. But 1 month after treatment initiation, we contacted all of them just to follow up, and you talked about how important is the close monitoring, especially in patients that suffer from so many symptoms, so many comorbidities. So I think this is one of the major factors that contributed to those results. We have that after 1 month and after 6 months of treatment, and in between we just collect recorded records of their medical records. We collect every information, if they reduced dose, if they had some surgery or increased medication intake, we document everything.
I have a question for both of you guys. Your clinical trial you did for chronic pain for kind of older patients. Did you choose patients who had diabetes? Because we know people who have diabetes have chronic pain, which is very hard to treat. That's my first question. Second question is that since you had a trial for over 6 months, did you see any memory loss in those patients, a temporary memory loss? They're forgetting some things. So if you could clarify that, that'd be very helpful.
So memory loss was, if you saw the list of adverse events, there was, it was one of them, but in minor reports. What was your first question? Sorry, I couldn't understand the accent.
How many patients did have diabetes?
Diabetes?
Sorry,
many,
the French.
Many. So I showed only the indication for cannabis treatment. You can receive, in Israel, you can receive the license for cannabis treatment only under one of the approved indication. Mm-hmm. Diabetes is not one of the approved indication, but something I couldn't fit into my presentation is the comorbidities. And many, I think, if I remember correctly, almost 30% of the patients suffer from diabetes, and the second comorbidity was hypertension. Mm-hmm. Many patients. So you saw if the patient on average suffer from 8.3 different symptoms at baseline, they are not taking 5 medication or 6 or 7 or 20 each and okay, now everything's okay. They still come, their condition was severe with multiple symptoms, multiple comorbidities, and medication burden, and that's how they came into the clinic. So we needed to reduce symptoms. Increased medication count wasn't one of the treatment goals at all. It was something we observed during the treatment because symptoms improved substantially.
Yeah, because why I'm saying that for the memory loss, my second question, that there were a couple of seniors taking these products in my city where I live, Tallahassee, and all of them after 6 months of using, stopped using it because they felt that but they're driving and they're forgetting where they're going, and they thought it was all linked to these, maybe the stuff they were using, the products, the indica base or sativa base, I do not know that part, but they did have that problem, which I talked to a few of them.
Definitely. So as I mentioned before, we contact all patients after 1 month, and maybe we have those reports. Maybe the reports of memory loss were higher, and then adjustments were made. Instead of high THC strain, maybe it was replaced by a high CBG strain or high CBD strain to reduce some of the adverse events. So patients after 6 months are already balanced in the adverse events, kind of, as much as possible. Thank you.
Good afternoon. My name is Dr. Wilson King, and as of January this year, I am the new president of the Society of Cannabis Clinicians. And you see, we have a booth this year. So we are moving about the country and letting people know who we are. I want to first thank Barry for bringing that up. We are the oldest organization for physicians talking about cannabis medicine. Todd McArea in California, when California passed their Medical Act in 1997, he formed the Society of Cannabis Clinicians. It was under a different name, but it's Society of Cannabis Clinicians. We have an educational system that is really great for physicians just starting out practicing, and it's for physicians who have been practicing to give you more in-depth and advanced information. We are in the process of revamping our educational system because it is now currently hour-long modules. Nobody wants to do hour-long modules anymore, so we're making them 3 to 4 10-minute interactive modules so people can get information. We're also creating a patient-oriented modules to really inform people about the processes. Then we also are training an AI bot that you can ask questions and you will get legitimate information from the SCC modules and Cannabis, which has over 10,000 articles from which we can glean our information from. So it will be legitimate information as it has been all along. So I really do encourage all of you to join the the Society of Cannabis Clinicians. We have quarterly meetings with speakers that you'll learn a lot of information from, and we're just really, I don't know if I want to say this, but I'm going to, the premier educational group for cannabis clinicians. Thank you.
And I just want to recognize and thank you for speaking at the first ever conference that we had.
Thank you.
Hello. Hi, I'm Dr. Kelly Enix King. There's no relation to Dr. Wilson King, but I respect her greatly. I just had a quick question. I have had a clinic now since 2017 in this space in Florida, but I'm a hospital trained, so my question is for Dr. Schleider. It was of curiosity. When I go back and forth to the hospital, which I still do, and then go to my clinic, I feel like I'm living in two different worlds, right? So I'm treating all of these chronic pain patients with great medical cannabis, and then I go to the hospital and I can't even talk to them about it. Or patients that I have, if they say they have a medical card, on their chart, the ER doctor has put on their chart, oh, medical cannabis use disorder, or, you know, drug addict, or whatever they've put. And they're really just medical cannabis patients that are treating their pain. So it's a source of frustration for me because I work in these two different worlds. And I understand in Israel, it's very different. Are you all able to treat patients in the hospital? Are you all able to treat patients? And I'd like to hear more about that.
Sure. So in Israel, you can receive medical cannabis only in a pharmacy, and only if you have a medical license, and it's not easy to receive the license. So there's only a certain specific list of indications that are approved for the treatment, and the Israeli Ministry of Health include a new indication only when there's evidence to base that product. If it's evidence-based, they will approve that indication. And for us, it was our major incentive for all the clinical trials we did. So we did a trial on autism, on cerebral palsy, on epilepsy, dementia, Parkinson's disease, Tourette syndrome. Every indication was for us an opportunity to allow more patients to use that amazing product that was banned for them. They couldn't reach any options because Israel is very, very strict. It's illegal. You can literally go to jail if you consume or hold a large amount of medical cannabis, but many patients suffer from multiple disease, and for us, every study we did was to open the door for a new group of patients, cancer and many others. I hope I answered your question.
Thank you. And Dr. Speyes, Rosado, Schleider, and Asike, on behalf of all of the attendees here, we want to thank you for sharing your research, your knowledge, and your wisdom. Thank you.